Okay, let's move on to our implementation treatment. So we've gone over prevention. Now we're going to go into how are we treating our patients. In your book, you'll find several different intervention chapters, and we aren't going to talk about all of them here in 219. Of course, we're winding down, but we are going to touch on a few of these. We're going to start with the anxiety and pain control because that's such a big component of what we do. Okay, let's talk about the objectives of dental hygiene process of care. So first we're going to talk a little bit about non-surgical periodontal therapy and how that's combined with prevention. So non-surgical periodontal therapy is our scaling and root planing, right? So we want to combine that with prevention. We don't want to have to scale and root plane every 3 months. And yes, some people do. They have such active disease that some offices do have to do scaling and root planing every 3 months until it really gets under control, until the patient understands the severity of it. So then prevention would include, how are they going to take care of their teeth outside of the office? Okay. Maybe it's using chlorhexidine, maybe it's using a perioid, whatever is specific to that patient, whatever is going to make the biggest impact on their oral health. So we want to discuss the total treatment needed, and our goal is to return the oral cavity to health and then to maintain that health. So we're going to aid in the prevention and control of diseases, right? What are our two main diseases? We have periodontal disease and dental caries are our two primary diseases of the oral cavity. Smooth tooth surfaces are essential to keeping the oral cavity nice and healthy, right? So anytime we have a rough surface, such as calculus on that surface, or maybe we have a margin, remember margins are where restorative material meets the tooth, and if that margin is not smooth, if it's a little rough, one's a little higher than the other, maybe it's open at the surface, that can cause a lot of problems and it's very difficult to keep clean. Then we want to give our patient good home care instructions, and that also includes instructions on how frequently they need to come back for dental care, okay, for preventive care. So maybe it's 3 months, maybe it's 4 months. I've seen patients every 2 months, 6 months, sometimes it's a year. If their oral cavity is nice and healthy and they haven't been in for 3 years and they come in, nothing's wrong. Now this is rare, maybe they don't need to come in every year. So just kind of keep that open and make sure that we aren't telling every single patient the same thing. All right, then we want to prepare them for restorative treatment, get their mouth as healthy as possible prior to having any work done, especially implants. It's really important that we don't infect those implants right away with the bacteria that causes periodontal disease, because it will be introduced to that area and the same problems can occur. And then we want to improve aesthetics and sanitation, right? Aesthetics aren't our first priority, but it's usually the patient's first priority. And then just, really keeping that mouth as clean as possible to prevent any further discoloration in the mouth, anything that they may not like. Nobody likes to have decay on their front tooth, right? So just keeping everything nice and clean and prevention. So we always want to look into our ethical applications. And first of all, let's talk a little bit about the relationship between the provider and the patient, and also the intraprofessional relationship. So the relationships between the staff in the dental office. I kept wanting to say faculty, the staff in the dental office, okay? How you talk to the dentist, how the dentist talks to you. And then also that relationship between you and the patient. That's always kind of the one we think of. But remember, they're watching everything. And we are subject, you can go down to number 3 or the third one here, and you can see subject to moral assessment. And we are always being assessed by our patients, okay? From before the appointment, during the appointment, after the appointment, and really even out in public, if they see us out there, we are being subjected to that moral assessment. Now, outside the office, not as much, but it is something you have to think of. So we just want to make sure that we are always practicing a consistent and professional demeanor throughout the day. And this also applies to school, right? This is where you're developing that professionalism. And we're just going to be held to really high standards now that you're in a profession. Okay? Let's move on to Chapter 38, Anxiety and Pain Control. Our learning objectives here describe the components of pain, summarize the advantages and disadvantages of nitrous oxide oxygen administration, define titration and its application with nitrous oxide oxygen sedation, I should say. List the local anesthetics of short, intermediate, and long duration and the indications for use. So we have anesthetics that last a little shorter, some that are a few hours, and some that are a little longer than that. And that depends on the procedure being done. Okay, how long is that procedure going to be? And what tissues are going to be worked on? Give examples of absolute and relative contraindications for local anesthetic administration. Identify the different items in local anesthetic armamentarium and the purpose of each. Summarize the different local and systemic complications from the administration of local anesthetic and how to manage them. And then write a complete record entry following the administration of local anesthesia. Okay, so let's talk about the ranking of negative dental stimuli. Over 50% of Americans are scared of going to the dentist. And of that 50%, a third of them don't go because of their fear. So we need to know what is it that makes the patient so afraid of going to the dentist. 68% of them reply that getting an injection is a negative stimuli. All right? Dental radiographs, use of curettes, the sight of dental needles, but it's the actual fear of getting the injection that's higher than the actual sight of the needle. Okay? So when we are in pain management, we're going to talk a little bit about that, and you're actually critiqued. Part of your skill assessment is that you keep that needle out of sight. Okay? Okay, so let's look at the components of pain. We have 3 of them here. In pain management, they say there's 2, okay? And those 2 are pain perception and pain reaction. Pain perception is the actual physical where that, something has been stimulated and the message is sent to the brain and it's saying something hurts here, okay? Then the reaction is actually how that patient, that's the psychological interpretation, how that patient is going to respond to that perception. Okay? Then we have the threshold. And the thresholds can be altered by a lot of different things. And so one of those is by drugs. Okay? So we can alter it by using local anesthetic. Things that can increase pain thresholds, we did talk a little bit about that in pharmacology, and that includes things such as not enough sleep, emotional, them having a little more emotional day. All of a sudden I'm drawing a blank on them. But there are different things that can alter, previous experiences, stuff like that, okay? But then we can heighten the threshold, meaning that threshold is more difficult to reach, and that can be done by drugs. All right, pain control mechanisms. So we want to match the pain, the anticipated pain, with the proper drug, okay? With that said, we want to, 1, remove the painful stimulus. So we could reposition a fulcrum, like if we're pinching their lip or something like that. So that's our first option, okay? Then we have the option of blocking the pathway of the pain message. And this affects the pain perception. Okay, if we go back to the previous slide, you'll remember that the pain perception is that information traveling from the stimuli to the brain. So somehow we're going to block that pathway so the brain doesn't know that something hurts. Okay? Then we have prevent the pain reactions by raising the pain threshold. So that is done in the dental office, at least, by nitrous oxide oxygen sedation. Okay, so it's just raising that pain threshold. Then we can also depress the central nervous system, and that's done with general anesthesia usually. That's when you go to the oral surgeon and they sedate you for your wisdom teeth extraction. Okay. Then they can use iatrosedation, or the use of psychological sedation. So the nice thing about this is that there's no pharmacotherapeutics used. So, you know, a lot of people are becoming a little more holistic, and they like that. And it builds a trust between the patient and the provider. They have to trust them also, right? I know one oral surgeon I worked for actually had training in hypnosis because some people didn't want any meds. So to make his job more easy and the patient more comfortable, he learned how to hypnotize. Okay, but you can use things such as relaxation music. Some people are using essential oils, and then distraction techniques. Some of you may have noticed like a dentist shaking somebody's cheek when giving local anesthetic. That's for nothing other than distracting the patient. Okay? Then we have our non-opioid analgesics, and we talked about these in pharmacology. We have our NSAIDs, such as ibuprofen and naproxen sodium. We have aspirin, which is our acetylsalicylic acid, and Tylenol, which is acetaminophen. Okay, those are all going to be, if you recall from pharmacology, those are going to be for mild to moderate pain. And that's usually used post-operatively. So you don't want to, you know, sometimes I'll say, yeah, go ahead and take some before you come in. But, you know, generally used post-operatively. Again, for mild to moderate pain. Now, that's what our book says, but we are finding that ibuprofen is generally better than most opioids for pain. It's going to be our best option, okay? But things we need to think about, remember our aspirin and our ibuprofen, naproxen sodium are all going to cause more bleeding during treatment, right? So we need to remember that. Key for your boards, we talked about this in pharmacology also, is that you need to know that the NSAIDs, that anything in this non-opioid category, they block the synthesis of prostaglandins at the peripheral nerve endings. Okay, so there's no CNS depressing there. All right, then we go to our opioids, and those are generally CNS depressants, right? And there's some pretty strong ones listed here, and that would be for mild to severe pain. Generally, these have been leaving the dental office due to all the addiction that has come about in the last 20 years due to overprescribing. So you're seeing less and less of this in the dental office and more of the opioid use. Excuse me, non-opioid use. All right, nitrous oxide sedation is very safe. You are licensed as a dental hygienist. You will be licensed to deliver nitrous oxide sedation. Overall, if you meet all the criteria and you do it properly, it's very safe. Do people die from it? Absolutely. And that's with abuse, okay? But when done properly, shouldn't be a problem. It is a state of conscious sedation. Your patient should not lose consciousness during the application of nitrous oxide. There is some degree of anesthesia. Remember, we talked about 1 or 2 slides ago about how it raises the pain threshold. So there is some degree of analgesia. Again, that is due to the higher pain threshold. Okay, characteristics of nitrous oxide is that it does produce analgesia. And what I want you to know is that 70% of the population falls in that 20 to 40% nitrous oxide delivery. So they're going to get the effects of the analgesia at 20 to 40%. So what happens is you combine the oxygen with the nitrous oxide. So you would have 60 to 80% oxygen and 20 to 40% nitrous oxide. Okay, so 70% of people fall within that category. You do need to know, need to know that. And it can fluctuate a little bit. One day a patient may not need as much as the next day, so you do need to always follow the instructions very closely so that your patient has a good experience with it. Okay, anxiolytic, we just want to know that that is kind of that it eliminates anxiety from the patient. So that's always a good thing, right? All right, and it does possess slight amnesic properties. Okay, so you would never want a patient to sign a medical history or a treatment plan when on nitrous oxide. So you need to do that when they're not on it. So in our practice, or at Herzing, you cannot have your patient on the nitrous oxide during the assessment because they need to sign the treatment plan, right? All right, so chemical and physical properties, it is a gas. We're just talking about nitrous oxide now. It is a gas. You need to store it at room temperature. It's heavier than air. It's got kind of a sweet smell to it. If any of you have had it, you know what that's all about. And it's non-flammable, okay? Blood solubility, relatively insoluble in the blood. Primary saturation of blood occurs in 3 to 5 minutes, okay? So pretty quick. The pharmacology of, also about blood solubility, what I want you to know is that there's a really rapid onset and a really rapid recovery. However, if the patient doesn't have pure oxygen for a while to eliminate all the nitrous out of their system, and they get up right away, they may be really dizzy and may faint, okay? And that's just from not having enough oxygen in the alveoli, okay? So please make a note of that. All right, pharmacology, it's not metabolized in the body. It remains unchanged in the blood and tissues. So it enters in the lungs and it exits out the lungs. You breathe it in, you breathe it out. It's a miracle drug. So that's kind of the gist of what you need to know as far as characteristics of nitrous oxide. All right, equipment for oxygen, or for nitrous oxide and oxygen. Again, they're in compressed gas cylinders. Nitrous oxide is going to be blue, okay? You need to know these. I want to say there's a question on your final about the colors, but I'm not 100%. But you do need to know these also for pain management in a couple semesters. So nitrous oxide blue, I always think of the ozone blue, sky blue. And then oxygen, we get oxygen from the trees, from the leaves on the trees, so they are green. Now that's in the US. Internationally, they're white. Okay? Not sure why we're different, but know that oxygen might be white. But if you only practice in the US, they are green. Okay? Nitrous oxide, blue like the ozone, oxygen, comes from the leaves on the trees, helps make it, so we're going to use green, okay? Don't get too focused on the PSIs or anything like that. You do need to handle them very carefully, and we'll talk a little more about that in pain management. All right, so delivery of nitrous oxide, we do have a regulator or reducing valve, so it kind of converts the high pressure of the gases in the cylinders to a more usable, much lower level. Okay. Then there's a flow meter, and that just gives us a visual of the number of liters per minute, and you will learn how to calculate that. But just quickly, I'll tell you, it is the respirations that you record. So you record respirations for 1 minute, you divide it by 2, and that's your starting tidal volume is what they call it, and that's how many liters you're going to give the patient. So it should never go above or below that. So as you're increasing and decreasing the nitrous and the oxygen, you're always going to stay at, say their respirations were 14, it's always going to stay at 7. Okay, so you may be 5 oxygen and 2 nitrous. Okay. Then we have a reservoir bag, and the reservoir bag is just well, it's a reservoir of the gases, and that's just so we can watch their breathing, and it kind of holds a little extra there in case your patient takes an extra deep breath. Okay, they will feel like they're suffocating if there isn't any in there, if they've sucked it all out. Okay, so we have to watch that closely. All right, then we have the nasal hood, nose piece, and mask. That's all part of just the part that goes across the face, and the patient then can help adjust that to make sure it's nice and clean. The scavenger system is an important safety feature that has been added to the nitrous oxide equipment, and it's just a little suction that's in there, and what it does is it takes out the gases that the patient is exhaling. So they should be breathing and exhaling through their nose, and the scavenge just takes out that extra, because remember, well, first of all, we could get the effects of it if they're breathing it out through their mouth, right? But the scavenger was helped to protect the clinician and help prevent those spontaneous abortions that we talked about previously. So it just kind of takes everything out of the office, so it protects everybody in the office. Safety features, one is having a universal color system, okay, other than the oxygen is white everywhere else. There is a pin index and diameter index safety systems, and they physically prevent the gas cylinders or hoses from being mistakenly interchanged. So what happens is, I believe one is like circular and one is octagonal, I think. So you can't put the wrong hose on the wrong tank, and that's a huge, wonderful feature. The minimum oxygen flow is 3 liters per minute, so we are always certain that they aren't getting just nitrous oxide. The minimum oxygen, the oxygen fail-safe system automatically shuts off the nitrous if the oxygen runs out. So that's huge, right? And then that's about all you need to know. There's also an oxygen flush button to supply 100% oxygen really quickly. Okay. Then we have maintenance, and just making sure that there's no gas leaks, following it to the system, to the delivery system. Make sure there's no holes in any of the tubing or anything along the way. All right, so here it is. You can see our oxygen is green, our nitrous oxide is blue, and it is held in a cooler external room, locked, and it goes through the walls, comes out the wall at the unit, and then it's hooked up to the delivery system here. Sorry, I thought I was drawing here. Okay, so it's coming up, and then this is our wall right here. Put a little star there. Okay, and again, the pins here are two different shapes. So this, we're going to say, has, I don't remember which one has more of an octagonal, and then one is more circular, so that you can't put them in the wrong spot and give the patient 70% nitrous and 30% oxygen, so, or 100% nitrous. So it's all pretty safe to use. And then we have, they don't have the scavenger system on here, I see. So anyway, there is a scavenge system. I think that's what this arrow is supposed to indicate, and then it goes to the patient. So you can see all these places where we can have leaks. Every place that has an arrow can have a leak. So we have lots of things that we have to watch and observe while we're delivering nitrous oxide. Okay, let's talk about our patient selection. So who would this be best for? This is going to be best for our patient with mild to moderate anxiety. Also for procedures that are really short in duration, they're kind of helpful. And patients with really strong gag reflexes, it really helps with. Okay, now contraindication, there's a whole long list, and I really want to refer you to your book to read all of these, but I'm just going to highlight a few. And let's see here, claustrophobic patients, children that can't listen, or even adults that maybe have mental illness that don't follow instructions would be contraindicated. Also, any congestion or COPD would be contraindicated, so anybody who can't breathe through their mouth. But one interesting one is the recent ophthalmic surgery using intraocular gases. And visual damage could result from increased pressure during the healing. So you would have to wait until after all the healing is done and maybe get a med consult from the ophthalmic doctor, ophthalmologist, before proceeding with nitrous. Okay? All right, here's a case study, and it's Mr. Jones is a 50-year-old male periodontal patient. He's been alternating scaling and root planing appointments every 3 months with your office and the periodontist. He has nitrous oxide sedation at every visit and says it's the only way he'll let a hygienist touch him. He suffers from stress-induced bronchial asthma and severe allergies. When you asked to review the medical history with him, he said he had had no changes other than an eye surgery last month. Okay, which of the following is the best reason to justify the use of nitrous oxide sedation? And this would be C, to help prevent his stress-induced bronchial asthma, right? Mr. Jones' recent eye surgery a month ago required the use of inocular gases, perfluoropropane and sulfur hexafluoride. Would nitrous oxide be contraindicated for this appointment? And the answer is C. Yes, you need to wait due to the use of intraocular gases. So just know that you need to wait, and then once it's healed, it'll be fine. You don't have to wait forever. You just need to wait until it's healed. So again, a med consult form would be necessary. Okay, patient preparation. You want to let the patient know in advance to eat a light meal. Anybody who eats too fast or eats a heavy meal is at risk for vomiting ahead of time. Make sure you explain the procedure before you get their consent. So it is informed consent, right? And then just make sure that you really evaluate their medical history, know their ASA classification, take their vital signs. Of course, we need it for the way we deliver it, and then place your patient in supine position. Then you're going to place the nasal hood on the patient. You're going to make sure there's no leaks, make sure it fits nice and snug. You're going to make sure that the scavenger system is connected. Some scavenger systems go through the high volume suction, but most, I would say, are plumbed in now, so you don't have to worry about that. But make sure your scavenger system is going. And then you need to turn on the gas cylinders. Now, we're going to vary a little bit from your book here, because your book tells you, as far as delivery, that you're going to start at 6 liters per minute, 6 liters of oxygen, and we don't do that. So we go by their respirations, okay? Half of their respirations. They have 14 respirations in a minute. We're going to use 7 liters, okay? So know that the adult is generally 6 to 7 liters per minute. Some are much higher than that, okay? And then you just want to adjust the airflow using the reservoir bag, and then getting feedback from your patient. Then titration, again, this is going to vary from your book, but what you need to know now is that you're going to start it at about 10 to 15% concentration, and then you're going to wait for 1 to 2 minutes, and then assess the patient, see how they're feeling, and then go from there. All right? So do you guys remember what the percent was that I mentioned earlier that most patients are going to fall in? That's in that 20 to 40% nitrous oxide. Okay? 70% of the population falls in that 20 to 40%. Again, you're going to assess the patient every 1 to 2 minutes. Now, subsequent titrating, your patient says, I'm feeling good, but I'm not feeling anything different, okay? Then you're going to increase it by 5 to 10%. Again, you're going to wait 1 to 2 minutes before you move on, okay? You're going to ask the patient, how are you feeling? At this point, we're going to be nearing that 20%, okay? So a lot of people are already going to start feeling it there. If you're in a higher altitude, say you live in Denver, Colorado, you're going to need more nitrous oxide, and that's just due to the partial pressure of the gases. So when you're looking at this, when you're starting the administration, it's going to take a good 5 minutes of your time to get the patient at the right level, okay? You're going to continually monitor the patient and just adjust until that patient is comfortable. I would say go more towards the 2-minute mark. That's when patients start to feel it. I notice in pain management, we say wait 1 minute after titrating, and it's right at the end of that minute where the patient's like, whoa, okay, yep, I'm starting to feel it now. Okay, so it's okay to take a little bit longer. All right, now, really important, make a note of this, write this down. This is something that will save you a lawsuit in the future. You never, ever, ever leave a patient that's on nitrous oxide. You should page the dentist or page the instructor if you're here at school, or notify a classmate, say you dropped an instrument or your suction just came off and dropped on the floor, needs to be wiped. You need to ask somebody to come and help you, so you can continue to monitor your patient, or your classmate or your instructor can monitor the patient, okay? Never, ever, ever, ever leave a patient. All right, so when you're completing the sedation, you want to make sure that your patient gets 100% oxygen for about 5 minutes. Again, as I told you earlier, without that, the patient may get up really fast and then faint because there isn't enough oxygen in the alveoli. So just know that you need to make sure that they are getting that 5 minutes of oxygen afterwards, okay? And also, you want to know that it is eliminated, 99% eliminated from the body within 5 to 10 minutes, so it's a pretty quick recovery. That fainting is called diffusion hypoxia, and that's, again, that is 100% preventable by administering 100% oxygen for at least 5 minutes. Okay, make sure that you allow your patient to fully recover before you let them go. There is new documentation by the state of Minnesota just recently that you have to state that you and the patient felt comfortable with them leaving. I believe you have to put you and the patient. You have to say what they looked like like actually give a description of the patient. Okay? All right, let's talk about occupational exposure. We did talk about this a little bit already in pharmacology. Potential health problems for the dental hygienist, reduced fertility with unscavenged nitrous oxide exposure. Unscavenged, okay? Spontaneous abortion, increased rate of neurologic, renal, and liver disease, and decreased mental performance, audiovisual ability, and manual dexterity. Okay? But the two biggest ones, reducing fertility and spontaneous abortion. All of this can be prevented by having a good scavenging system. Now you can wear a badge that can determine how much you're getting, so there is always that option also, okay? Methods for minimizing occupational exposure, use an effective scavenging system that can move 45 liters per minute of air. You don't need to know that for this class, but you will need to know that for pain management, okay? All right, and just have a good air exchange in the office, okay? Good air quality is really important. Advantages and disadvantages of nitrous oxide. One, it increases the relaxation and cooperation of the patient, so that is a huge advantage for both the patient and for you, right? It reduces the gag reflex. It's really safe to use. There's no known allergies. There's a whole list in your book of all these great benefits. And just, having your patient slightly relaxed with this can mean the difference between them coming back and them not coming back. Now, disadvantages, it is a low potency analgesic, so you still need to get your patient numb, okay? So people who are extremely phobic may need the use of drugs, or maybe go to an oral surgeon's office. Patients have to be willing to breathe through their nose, so if they can't or they won't, it doesn't work. Equipment gases are super expensive. I just got the cost of it recently for our clinic, and I believe the nitrous tank was $460, I think. So, and we go through several of those. So it is very expensive, and it kind of fluctuates. Also, I'm not sure why, but I know the cost can really go up and down. But do know that it is very expensive. So a lot of offices do charge, $60 to $90 for it. And insurance usually doesn't cover that. One thing you need to be cautious of is that it may stimulate sexual fantasies. And so that can go two ways. One, they can think that you were doing something to them, or they may attempt to do something to you. So you really want somebody else in the office, and you want to make sure that they aren't that heavily sedated, okay? That they have that reaction. All right, so going back to our case study earlier, Mr. Jones was on a 20% concentration. How soon would you assess this initial dose? That is going to be 1 to 2 minutes, right? You guys shouldn't have even had to think about that. It's indicated in Mr. Jones' record that the concentration he needs is 20 to 40%. What percentage of patients fit into this dose requirement? And that is E, 70%. All right, you just finished scaling his teeth. You get up and take off your gloves and rinse your hands. The receptionist is waving at you to come up to the front desk. One of your morning patients is on the phone and wants to ask you a question. What should you do? And that is stay in the room with Mr. Jones and tell the receptionist to take a message. You never, ever, ever leave your patient. Mr. Jones takes his mask off immediately. That's not good, right? Because he was breathing nitrous oxide when you finish scaling, and he says he needs to use the restroom. When he stands up, he complains of a headache and faints. What is the cause of his syncope? And that is A, inadequate oxygen in the alveoli. Okay. Okay, let's talk about local anesthesia. Local anesthesia is the our main vehicle of pain relief in the dental office. Okay, so you will be administering, plenty of local anesthesia. And what it does is it just blocks the sensations. So it's blocking that signal to the brain, so that pain perception, right? And when we do root instrumentation, so say we're doing scaling and root planing, it's really nice to have them numb, but there's so much sensitivity that you usually need to have pulpal anesthesia. And so it usually is indicated, local anesthetic is usually indicated for scaling and root planing. Okay, let's talk about the pharmacology of local anesthetics. We've already talked about this some, but I want you to know that most cartridges are 1.7 or 1.8 milliliters. It just depends on if they round up or down. They're all the same. It's just they're 17.6, I think, and some round it down and some round it up. So do know that that is different from different drugs. Everywhere else they do 1.7, but for some reason in the US we always write 1.8 because we round up. So there are amide anesthetics and ester anesthetics, and esters do cause more allergies. So that is our actual Novocaine. And we haven't used amides in dentistry since, or excuse me, we haven't used esters in dentistry in over, I want to say 70 years. So if people say they're allergic to Novocaine, they're not allergic to Novocaine because how would they know? It's not been used. But they may be allergic to something else. You just need to find out what it is. So it usually includes the amide anesthetic, a vasoconstrictor, so that's like our epinephrine, an antioxidant to preserve and prevent oxidation of the vasoconstrictor. So if people are allergic to the preservative, we don't have to worry about it if it's a carpule that doesn't have a vasoconstrictor in it. So if we use carbocaine without a vasoconstrictor, or mepivacaine is the generic name, and there's no vasoconstrictor, and they say that they have an allergy to the preservatives, well, we don't really have to worry about that because the preservatives are only added for the vasoconstrictor. Then there's sterile water and sodium chloride, and that just makes it biocompatible with the body. All right, ester and amide anesthetics. Again, as I told you, the ester has more allergies, so we only use it as a topical agent in dentistry. And that's about all you probably need to know for now, other than it is eliminated by the kidneys, where our amide anesthetics is eliminated from the kidneys also. And it causes vasodilation. I don't want to get too much into this, just let you know the generals. So the duration of amide drugs, we have short acting, which is roughly 30 minutes of pulpal anesthesia. Then we have our intermediate, which is roughly 60 minutes, and then long acting, which is roughly 90 minutes, all of pulpal anesthesia. So pulpal anesthesia is our most profound anesthesia, and the pulp is the last thing to get numb, and it's the first thing to not be numb. Okay, so that's why they say pulpal anesthesia, because the soft tissues are going to get numb before the pulp. Okay, so we still may be able to do some things to the gingiva, even though the pulp is coming back. Okay, the feeling is coming back. So things that influence the duration is just the patient's individual response to the drug, which injection you gave them, the accuracy, how close you were to that nerve, and how much blood supply there is to the nerve. Again, we'll get into that a little bit more later on. Lidocaine is our most used amide drug, and it is more of an intermediate. And I'm not going to make you guys figure out the maximum recommended doses yet, because we'll do that in pain management. All right, so vasoconstrictors. We use 2 different vasoconstrictors here in the US. One is neocobaphrin and the other is epinephrine. And nobody is allergic to epinephrine because it is a natural occurring chemical in the body. So they may be allergic to the preservatives, the sodium bisulfite. Okay? So again, what we would use is something plain, mepivacaine plain or prilocaine plain. Okay? Criteria for local anesthetic selection. We want to make sure that the duration matches the procedure that we're doing. If we know that we need pulpal anesthesia for 90 minutes, well, then we're going to use more of a long-lasting. But if we only need pulpal anesthesia for 30 minutes, say you're doing scaling and root planing and you have an hour, well, it's going to take, a good 5 to 10 minutes to go over medical history, get them started on nitrous maybe, and then you still have to go over instructions and everything at the end, get consent. So you really probably only need that 30 to 60 minutes, depending on if you have an hour to an hour and a half. All right. But, play it a little on the safe side, but you don't want to overtreat. You wouldn't want to give a 90-minute, because that way when they leave, they could bite their tongue and cause bleeding or damage to their lip, whatever. So you really want to match it with the length that you need. Also, do you need bleeding control? If you need bleeding control, then you definitely want a vasoconstrictor. If they have heart problems, then you don't want a vasoconstrictor, right? Or maybe just two carpioles of a vasoconstrictor, and then maybe pick up with something without a vasoconstrictor after that. So a lot of things to consider when we're looking at selection of local anesthetics. All right, here's our pregnancy categories. Make sure you know those. Again, we're going to go over that in pain management. All right, indications for local anesthetic. Basically, anything that might put the patient in pain or cause them to have discomfort. It's just easier to give them an injection. It's quick, easy, and they can then not have to worry the rest of the appointment. Okay, but we also want to make sure that we know, if this is somebody who might self-mutilate, we maybe don't want to give it to them, right? Okay. Patient factors, so just their oral health status. Some people just have a lot of pain, and they have really red, inflamed gingiva, and maybe you're only doing a prophy, but they might need to be numb for it. So then you might do the prophy in 2 appointments, getting them numb. And then, what is the patient's pain threshold? Maybe they have a really high pain threshold and they don't need it, right? Or maybe they have a super low pain threshold and they would need it more than most. Okay, patient assessment. Sources of information for complete pre-anesthetic assessment. You want to collect all your data. So anything that would go under the subjective in your SOAP notes, our chief complaint, our vital signs, our medications, medical history, dental history. And treatment considerations based on the assessment findings. You want to make sure that you're going to administer this as safely as possible. So you want to use local anesthetic without any special precautions. You want to avoid the use of local anesthetics or of specific local anesthetics because of high medical risks. Limit the dose of drug given to any specific appointment. So, you don't want to give them 12 carpioles. If they aren't getting numb that day, then maybe you just need to reschedule them for another day. Select a drug that's going to minimize the risk. So your patient that has heart disease, if we can, if they only need to be there for a short period of time, let's give them something that's short lasting, okay, without epinephrine. And then just make sure you seek any consultations if you have questions ahead of time, okay? Let's see here, general medication considerations. Make sure you know your ASA classification. ASA 4 patients and some ASA 3 patients may not have the functional reserve to tolerate an injection procedure, so maybe we need to consider other options, all right? We've already talked about most of the risks here. And then specific medical considerations always include allergies, probably from, trying to think of the course, medical emergencies. You'll remember that hyperthyroidism, you'd want to definitely avoid using a vasoconstrictor on that patient. Maybe consider using mepivacaine plain. Anybody who has impaired kidney or liver function, you really want to be careful because the drug isn't being metabolized and excreted, so they can become more toxic faster, so they can get poisoning faster. And then our malignant hyperthermia, we're going to talk about that more in pain management, along with methylglobulinemia. So we'll talk about all those later on. Okay, so if you're following along in your book, you're now going to notice that we jump way down to non-injectable anesthesia. And non-injectable anesthesia is currently the biggest one is Oracix, and it's 2.5% lidocaine and 2.5% prilocaine. And what you do is you just squirt the gel, it comes as a gel, squirt it around the tooth to anesthetize those gingival tissues. So if you're doing scaling and root planing, it's not going to give you that profound pulpal anesthesia. So if those patients who maybe the pockets aren't as deep on, or maybe you're just doing 1 or 2 teeth and you think, hey, this patient has a really high pain tolerance, this is a great option for them instead of getting an injection. So I'm not going to get too deep into all of this just because we do that again in pain management. Okay, topical anesthesia. Topical anesthesia is indicated when you're giving an injection. You will place the topical anesthesia on the oral mucosa where you will be injecting. It just provides some surface anesthetic right where the needle penetrates into the tissue. There are several different kinds of topical anesthetics. There's benzocaine and lidocaine are probably the 2 most common ones, and those are the ones that we have here at the clinic. Benzocaine is a ester, and lidocaine is an amide. So if they do have allergies to esters, they would use the lidocaine instead of the benzocaine. But benzocaine works really well, so generally people are going to use that. Adverse reactions of topical anesthetics can include just some redness and tissue sloughing in the area, maybe a little bit of inflammation. And this is often due to maybe keeping it on too long also. There may be pain also, kind of like a burning sensation in the area. But again, that's usually because it's been left on too long. So when you're placing the topical anesthetic, you're going to first make sure that you explain it to the patient and what they can expect. Then you're going to clean the area. You can use an antiseptic or just wipe it with a gauze and apply it to the area. And depending on which type of topical you're using. It could be in a spray or just on the end of a cotton tip applicator. It will be placed in that area and generally given a couple minutes to work. Okay. So like I said, there's many different types of applications. It can be surface application, which is like a gel or a liquid, and then we have the aerosol spray. So you want to wait the proper length of time. So always make sure you read the directions. Anytime you're applying anything to a patient, you want to make sure you read the directions. And you want to limit the dose and the exposure. So only use as much as you need and really watch the time. Okay, we have a couple new developments in pain control. One is Auraverse, and that helps reverse the effects of the local anesthetic, which was really good for patients who are at risk of biting their cheek, or for patients maybe who have a meeting after their dental appointment. And it is delivered just like an injection. It comes in a carpule and is delivered with the same techniques. And then we have buffered local anesthetic, and that just helps increase the pH of the local anesthetic and reduces the stinging on the injection, and also it creates a faster onset. And intranasal dental anesthetics haven't gotten FDA approval yet, but I think it might happen in the near future. And it's great for anterior teeth. It's just a kind of like a flu mist where it's just puffed into the nose, and they can get anesthetic benefits on those anterior teeth. Documentation, always include the date, the medical status, the ASA, and vital signs. Review of the dental and psychological history. Always get informed consent. Rationale for pain control use. So why are you doing it? You have to have that in there. Location and type of injection, the time of administration, and the number of cartridges. So you also want to add the type and concentration of the local anesthetic and the vasoconstrictor in milligrams of the drug administered. Now, when they talk about, which one was it here? Time of administration, that's usually for nitrous oxide. You have to put the time down, but not generally the local anesthetic. Factors to teach the patient: nitrous oxide, conscious sedation, inform the clinician if the sedation becomes too strong or too weak. The gas will not result in an unusual or undesirable behavior. And eat normally before the appointment. Avoid fasting or heavy meals. As far as topical and local anesthetic, you want to tell them to be careful not to bite their lip or cheek or tongue while tissues are without normal sensation. Avoid chewing hard foods and avoid hot drinks and foods until normal sensation has returned. And that's just to avoid any burning of the soft tissues. Okay, Chapter 39, Instruments and Principles for Instrumentation. Learning objectives: name and describe types, features, and properties of manual instruments used for complete removal of calculus and biofilm deposits and smoothing the root surface during non-surgical periodontal therapy. List and describe the 5 basic principles for use of instruments, namely stabilization by instrument grasp and fulcrum finger rests, instrument adaptation, angulation, lateral pressure, and stroke. Apply clinical factors relating to the patient and clinician to provide appropriate lighting and visibility. Relate the choice of each selected instrument to the anatomy of the tooth surface and the periodontal soft tissue under treatment. Prepare treatment plans for patients of varying ages and disease severity. Connect instrument choices for setup in the sterilized instrument cassette to meet the needs of the typical diagnosis and treatment plans. Okay, instrument identification, recognition of treatment instruments. We have several different instruments that we use. We have calc removal instruments, and then we have assessment instruments. And our examination or assessment instrument would be our explorers and our probes, okay? Then we have our calc removal instruments. We have scalars, and then we have curettes that are universal and curettes that are area specific. So we'll go over this much more in 199, to the point where you guys will be dreaming about these instruments. You're going to know them inside and out. But universal means it can be used anywhere in the mouth, where area specific is just that, area specific. Classification for dental instruments, there's the design name and the design number, which is the traditional number used to identify the specific instrument. So if you're using, say you have calculus on the distal of number 3, your patient does, and you want to use an area specific instrument that goes just to the distal, well, then you're going to look at your 1314 Gracie. Okay, so they're going to have numbers and names, or sometimes just names, but usually they have numbers and names. So you'll have your McCall's 1718 or your Gracie 1314, all sorts of things. It can get a little confusing, but we're going to walk through all of the characteristics in preclinic, and you're going to know everything you need to know about them. All right, so things that help classify the instrument would be the handle and the working end, okay? The blade, whether it's tipped or angled or not, and the shape. Okay, so let's talk a little bit about the handle. The handle comes in various sizes that can make it your ergonomics a lot better. You don't want anything that's too small or too fine like a pencil, because imagine writing with a pencil all day and removing calculus with a pencil all day. The pinch force, we call it, how hard you have to pinch it, can really cause a lot of problems. So of all the following, which would you consider an examination instrument? And that would be E. All right, instrument parts and balance. So we have our working end, and if you have a curette, it's going to be a rounded working end, and if you have a scalar, it's going to be a triangular working end or a pointed tip, okay? The shank is the part of the instrument that connects the working end with the handle. And I'll bring some instruments into class for you guys to take a look at this, okay? The shank can have varying shape, length, and rigidity depending on what you need and where you need to use it. Then again, we have the handle, and generally you're going to have tips on each end of the handle, unless you're using a mirror. Then it's just a mirror, okay? And that, of course, is going to be where you're handling it. The weight of the instrument is especially important because, again, you're going to be holding these all day. So we need to take into consideration when we think about ergonomics, the weight and the diameter. Also, the texture of the handle is important. If it's really smooth and no texture to it, imagine, pulling up on something hard, how easy it would be to slip. So you want something with a little bit of a texture so that your gloves and your fingers can grasp it better. All right, instrument balance. Just know that the working end of a balanced instrument is centered in line with the long axis of the handle. And that's going to be important when we start talking about the working end and how we're going to remove the calculus. All right, so here's our handle here, and you can see this is textured in here, okay? This is what we call a simple shank. It's nice and straight. There's no curves here. Oh, and then our blade is on the end, on the side of the working end. So this is the working end. Oh boy. Just gonna put W-E. Okay. Now, if I were describing this instrument, I would say that it has a simple shank, one cutting edge. That's the blade. There's only one edge here. This is my lower shank here. And this is the whole shank. Okay. And that lower shank plays a really big role once we get to area specifics. Oops. Oh boy. Can always tell when I'm not using my surface. All right. So notice that the lower shank and the shank are a little bit different. Okay. The whole shank includes the lower shank, and then we have our lower shank. We call them a little bit different in 199, but we'll get into that next semester. Okay, so we got the blade, we got the working end. This is a curette because it has a rounded tip right here. Okay, you can see here it's rounded. Okay. All right, this is the parts of the curette. We have the lateral surface, our cutting edges. An edge is just where two surfaces come together, right? So this is where our blade is. Okay. This is our toe. When it's a curette, it's a toe. When it's a scaler, it's called a tip. The face of the instrument is kind of like the inside of a shovel. It's where the snow would go if you're scooping snow with a shovel. Okay, or the dirt if you're, we're just coming off winter now, so I'm thinking of snow. But if you are digging the dirt, the inside of the shovel where the dirt will go, that is the face. All right, then the back is opposite of that, and then the two lateral sides. Here's a bunch of examples of the handles, varying textures and diameters. You can see how thin E is versus A, and your instruments will be A. These two, B and C, are plastic, which means they're going to be a little lighter weight. But generally, most instruments are going to be more of this stainless steel handle type, okay? All right, and this just shows the balance, how the working end or the tip is balanced with the long axis of the instrument. Here's our curved scaler. What you need to know about a scaler is that this cutting edge is 70 to 80 degrees. Okay, that's going to be really important in the future. Again, we're going to go over that a lot next semester, so we're not going to get too into it. And this is actually, this is not a sickle scaler. A curved scaler. Okay, so this, all right, so a scaler is usually triangular in cross section, so we're not going to, this shows a curette, so we're going to X that out. Let's see if my mouse can help me draw this a little bit better. What I want this to look like is more of a triangular cross section, okay? And these are going to be 90 degrees. Okay. Okay, treatment instruments. We have several different categories. We have scalers, we have curettes, we have universal curettes and area-specific curettes. We also have files that help kind of crush up the calculus, those large burnished areas, burnished meaning it's been smoothed off from improper instrumentation. The instrument blade anatomy, generally if they're universal, it's going to be at 90 degrees, and if it's area specific, it's going to be at 70 degrees. That's the face to the blade. All right, universal curettes, I'm not going to have you guys worry too much about this. I think we're going to skip through a lot of this, but universal curette, again, can be used anywhere in the mouth, okay? Generally, they're going to be used in the posterior because we're going to use scalars and area specific in the anterior. But the face of the instrument is going to be at 90 degrees because it is universal, so you're going to have to angle it just a little bit because we want to try and get that 70 degrees. It has 2 cutting blades per working end. And in cross section, it's going to be semicircle. So let me draw that. Again, it's going to be semicircular in cross section. You're going to have a blade here and a blade here. Sorry. There we go. All right, so semicircular and cross section, 2 cutting edges per working end. That means 2 blades. These are used for moderate, light to heavy calculus, so it can be used almost anywhere. Again, you will need to angle it because this is going to be about 90 degrees. All right, so internal angles of the curette. Here we have our area specific curettes, and you can see a standard Gracie. The length of the working end is the same as that as a after 5, and after 5 is used for periodontal assessments. But the after 5, because of the periodontal disease, the deeper pockets, it's going to have a longer lower shank or terminal shank. Then we have the mini 5 curette, which has a shorter working end, but still has the longer shank, terminal shank. And then we have our micro mini, which is super thin tip and a nice long shank. Okay. Now scalars. We're going to mainly talk about the sickle scalars. We do have some jaquettes that I believe you guys might get this year. I can't remember if they were ordered. But sickle scalars are, triangular in cross section. They are universal. So right here's a cutting blade and right here's a cutting blade. And jaquettes are just a little more rounded. So it's kind of a cross between a scalar and a curette. Okay, so it doesn't have these sharp, well-defined angles. Then we have file scalars, hoe scalars, and chisel scalars. We'll get into those next semester. Actually, it'll be in 2 semesters in your 320 class, I believe. All right, and this is our jaquette scalar, and you can see it kind of comes up, curves nicely. Little softer sides here. A lot of people really like these. I don't have a lot of experience with them. I've used them some. I like the straightforward sickle scalars. All right, and then here's our typical scalar. You can see this more well-defined angle. All right, these are our files, and you can see they have multiple cutting blades here. And like I said, these are just used to absolutely crush the calculus. Then we have diamond-coated files, and that is nice just to remove that last little layer of endotoxins that might be in the cementum. You can do a lot of damage with these, so you have to use them very judiciously and very cautiously. All right, here's a little hoe scalar. Nice for getting right under that cingulum on the anterior teeth. So principles for instrument use: know the purpose of use for each instrument. Is it used for heavy calculus, tenacious calculus? Is it used supragingivally? Our scalars are always used supragingivally. and our curettes can be used supra and sub. Okay. Stability, having a good fulcrum, and you're going to learn about that again next semester. Having stability is really important, especially when you get to those hard to remove pieces. If you don't have a solid foundation with your hand, you're going to slip and injure either yourself or your patient. So that also plays into the control. You want to make sure you have good control over your working strokes. Instrument grasp. Know the functions of the instrument grasp, types of grasp. There are a couple different depending on what you're holding. So in your dominant hand, you're usually going to have a modified pen grasp is what it's called, and it is very similar to how people should be holding their pen. And I say should be because a lot of people don't hold their pen right, I'm finding. And then you have a palm grasp, which would be how you would hold your suction. Okay, so there are a couple different types of grasp. You want to always maintain good neutral positions of the wrist, elbow, and shoulders. Again, we'll go through that next semester and hopefully have a guest speaker for that position or that class on positioning. Here's our modified pen grasp. Note that the ring finger here is stable on a tooth. That's our fulcrum. The pinky doesn't really do much. The thumb and the index finger, if you guys wanted to start practicing, need to be across from each other. They shouldn't be touching. You can see that there's a little gap here. And then your middle finger goes onto the shank here, the upper shank. Okay? And that will help you detect the calculus with an explorer. You can feel the vibrations on your middle finger. Okay, so let's talk about our finger rest quick. The definition of a finger rest is basically just that, a place where your finger rests. And it ends up being kind of your power when you're removing calculus. Having a good foundation. It's like you want to think of it as just a pull going straight from the tooth through your finger, and then you can move the calculus a lot easier. Okay? So the objective is just to establish a good finger rest to remove calculus. Stability is super important for control and action of the instrument. So like I said, if you don't have a really strong finger rest, you really risk injury to yourself and your patient. There are intraoral fulcrum rests. As you saw in that previous picture, it was on a tooth. That would be considered an intraoral. And then extraoral, you'll have, you get to practice that more towards the end of preclinic and then the next semester in advanced instrumentation. Then there are alternative fulcrums. Again, we'll talk about that in the fall. And then touch or pressure applied to the finger rest. So, you know, just skim over this, kind of know the general definition. You don't need to go into heavy detail with this, okay? Adaptation is just how you are applying that instrument to the tooth. And I think we're going to kind of skip over this until next semester, just for time's sake. Okay, here you can see a nice neutral wrist position, and you can just see how damaging B would be and how that would pinch your nerves in your wrist. So you really want to maintain that nice neutral hand positioning. All right, let's just briefly talk about angulation with assessment instruments. Your probe is going to be adapted with the working end almost parallel to the tooth surface. The explorer, you want to explore with the sides of the tip of the instrument. So we talked about that a little bit previously, that you're just going to use the sides and not cavitate into it, not use the point, right? And you want the angle to be about 5 degrees or less. So it's going to be pretty similar to the long axis of the tooth, okay? Now, instrument adaptation for the Explorer, you can see here in A how well adapted it is. This is where it becomes really important for you to know the curvatures of the tooth, okay, because you won't be able to see this. This is going to be more interproximal. And if you aren't turning the tip, you can see in B, they aren't turning the tip to adapt to the tooth. And where do you think that tip is going to go? That tip is going to go right into the tissue surrounding the tooth. So, and you aren't going to feel if there's any calculus or any defects there, okay? Now, lateral pressure with detection instruments is going to be very light so that you can feel the vibrations of the deposits, okay? So our assessment stroke is going to be light pressure and longer strokes. So light and long, okay? Then our scaling stroke or working stroke is going to be more short biting strokes. They're going to be very well controlled short biting strokes. Then we have our root planing stroke, and really the amount of pressure that you're going to apply here depends on the textures of the tooth and the deposit on the tooth. So lateral pressure begins as fairly firm if deposits are present. Now, as strokes continue, a lighter pressure is applied progressively as the root surface becomes smooth. So you start out with a little heavier pressure, and then you're going to move to a little lighter pressure. So what do you think could happen if the incorrect lateral pressure is applied? So the biggest concern is burnish calculus. When we're using calc removal instruments, when we don't apply enough pressure, you're just going to shave off that roughness that you feel, and all of a sudden it's going to be nice and smooth, but it's going to be smooth calculus rather than smooth cementum. Okay, so that's our biggest one. And then also just losing control. If you don't have good lateral pressure, you might lose control of the instrument. With excessive pressure, so that was with insufficient pressure. With excessive pressure, loss of control, and that's where you're going to slide off the tooth and hurt somebody, okay? So it's also going to cause a lot of fatigue in your hand and in your wrist and forearm. So, you know, sometimes when people first start out, they apply a lot of pressure everywhere. Well, you're removing excess tooth structure, you're fatiguing your arm, and you're losing control. So you really want to make sure that you're applying the proper amount, and that does come with a little bit of time and training, okay? Okay, activation stroke, just know that this should be unbroken. So when you're applying the stroke, it should be nice and flowing, okay? Especially with the exploring or your assessment instruments, you're probing and exploring, it should be nice, flowing, uninterrupted strokes. Your scaling stroke is going to be, again, short and biting, and then your root planing is going to differ throughout, right? You're going to start with a more firm and then let off on it a little bit. So just know that it is going to vary some depending on the instrument selection, and just having good balance of pressure, especially with that root stroke, okay? The requirements for putting the instrument into action to accomplish a particular task are stabilization by means of a correct grasp and finger rest, and all of the following except one. Which one is the exception? Indirect vision, okay? So indirect vision is not part of our instrumentation sequence. Okay, that kind of leads us into this next slide, which is visibility and accessibility. It is really important that you're able to see the area that you're working in, and I know that kind of sounds silly right now, but in the future you're going to see why I say that, because it's not always that easy. What I want you to know is that this can often be altered by patient positioning, operator positioning, and using your mirror as a tool to shed light onto the oral tissues. So what do you think might cause the inability to see, to have good visibility and good accessibility? Okay, so again, it is the patient and clinician positions, right? And use of the mirror. So make sure that you're taking the time to position your patient well and yourself without compromising your ergonomics. Okay, let's start talking about dexterity development, because this is something you guys can do from now until, a few weeks from now. You guys are going to be in pre-clinic, and you're going to, after the first few weeks, start working on your modified pen grasp and your strength for removing calculus and assessing, okay? So start squeezing a therapy ball or a soft ball. Make sure you stretch your fingers. Your book has a nice picture of just putting a rubber band around your 4 fingers and starting to separate them by stretching that rubber band, okay? And you do 1 finger, keeping 3 together, then you do 2 fingers, keeping the other 2 together, and then 3 fingers, keeping the pinky apart, okay? Taking the pinky apart. Writing or stretching, I'm sorry, that goes in with the rubber band. Then writing, start using your modified pen grasp to write and draw circles, draw whatever you can to start training your muscles. You need to start creating muscle memory, okay? Mouth mirror, cotton pliers, and explorer. You want to develop the ability to turn the mouth mirror at various angles. I know it sounds kind of silly, but you need to work on that. I also developed dexterity in holding objects with cotton pliers. So you guys don't have any cotton pliers at home, but if you have anything that kind of pinches together, work on picking things up with that, okay? And then just, again, maybe with your pencil, use that nice modified pen grasp and just draw oh so lightly so that you're barely hanging on to the instrument, but you're holding onto it enough to where you can feel things, okay? I know that's hard to explain, but we'll do a little activity in class, okay? Tactile sensitivity is just the vibrations that you feel when an assessment instrument goes over a piece of calculus or over a filling, any irregularity in the tooth surface. Prevention of cumulative trauma. Problems that we often see that affect ergonomics is posture, and then the amount of time that you're working. Some offices have 10-hour days, so you need to make sure that your position, that you're using really good ergonomics and positioning yourself properly. That when you're getting up and bringing your patient out, maybe on your way back, that you're stretching and taking care of your body as you're going to sit there again for another hour, okay? So maximize the time that you have to actually stretch your fingers, stretch your body. Because the problem with dental hygiene is that we're using repetitive motions all day. So we need to somehow counteract that, okay? Exercises, the book does have some. When people are instrumenting, they tend to lift 1 or 2 shoulders because they're really focused on something and they kind of tense up. So you want to start maybe doing some shoulder exercises to help relax those muscles and stretch them out. You can do there's a really good video on YouTube, a yoga video. It's short, easy, and just really helpful for the students. They all say they wish they would have had it earlier, okay? So make sure you're doing exercises and especially stretching exercises. When you're working clinically, just make sure that that you are performing exercises chairside also. and between appointments. So I just really want to emphasize this, and I do go over it really thoroughly next semester, okay? All right, so here's the stretching and the putty ball. Here's the shoulder shrug and big shoulder rolls that can help with stretching your shoulders out. Just stretching your fingers just prior to instrument retrieval. Before you go in there, just stretch your fingers. All right, documentation. You're going instrument selection. You want to document for subsequent appointments. What worked well, what didn't, right? Areas requiring more attention. Maybe they had a lot of calculus buildup in the lower anterior that took a little more time than you anticipated, or than the average patient. You want to make sure you note that so that it just helps you at future appointments. Factors to teach the patient: necessity to use a variety of instruments, need for several appointments oftentimes, and the relationship of personal daily care to need for daily care. I'm sorry, I don't know. Relationship of personal daily care to need for, I think it says, I think it's supposed to say, and need for frequent appointments. Sorry about that. All right. Chapter 44, Dentin hypersensitivity. Learning objectives: describe the stimuli and pain characteristics, describe factors that can contribute to dentin exposure, address behavior changes that could decrease hypersensitivity, explain hydrodynamic theory and why it is considered the theory instead of fact, describe the two modes of action of treatment modalities, and explain design challenges in conducting sound scientific research on hypersensitivity treatments. Dentinal hypersensitivity defined. So let's talk first about the stimuli that elicit pain reaction. That is tactile. Tactile is the touching of the area that's sensitive. Okay, so touching it stimulates the pain reaction. Thermal, whether it's hot or cold, either one can elicit a pain reaction. So again, thermal is whether it's hot or cold. Things that we need to consider as a hygienist for tactile would be exploring it or instrumenting it. And then thermal, if we're squirting our water on it or putting air on an area that's sensitive to temperature, that can be really uncomfortable for our patient. Then we have evaporative, and that's the dehydration of the oral fluids. This can happen with our high volume suction. It just kind of sucks everything out of the tooth and thus causing sensitivity. Then we have osmotic, and that's the alteration of pressure in the tubules, and we've talked a little bit about that, and that's where our Sensodyne and stuff work so well in that case, okay? Then we have chemical, and that's usually from acidic foods and drinks, okay? Let's talk about the characteristics of pain from hypersensitivity. There is sharp, short, or transient pain of rapid onset. So all of a sudden the pain appears. It's sharp, short, or it could just be coming and going. Then we have cessation of pain upon the removal of the stimulus. Did the taking the suction away eliminate the pain? Taking heat away, does it eliminate the pain? Presents as a chronic condition with acute episodes. So it's something that usually takes a stimuli. If it's hypersensitivity, it's going to take a stimuli. Okay, we just listed those in the previous slide. And it's chronic, so it continues over a long period of time. And then its acute episodes are when that stimuli is elicited. Okay? Pain is in response to a non-noxious or non-harmful stimulus, one that would not normally cause pain or discomfort. So generally, we can use the suction in the patient's mouth, but somebody with hypersensitivity can't. Okay? So we're just talking about hypersensitivity here. We're not talking about an abscessed tooth or anything like that. This is just hypersensitivity. All right. And then discomfort that cannot be ascribed to any other dental defect or pathology. I'm not sure what happened to the words there, but they're not there. But basically, you can't answer it any other way. Okay, there's no pathology, there's no infection, there's nothing else. It's just there. Okay, so let's talk a little bit about tooth anatomy. I know this is a little redundant, but I want to talk about it because it is so essential with hypersensitivity. So the crown portion of the tooth is always covered with enamel, then dentin, then pulp, and the pulp is what holds the nerves, right? Then the root surface is covered with cementum, then dentin, then pulp. Again, the pulp is in, or the nerves are in the pulp, and they can extend a little bit into the dentin. So what happens with sensitivity is somehow there has been a kink in the enamel or in the cementum that has left the dentin exposed. And in hypersensitivity, you're going to notice wider tubules in those areas. And in order for sensitivity to occur, it has to go into that tubule and pretty far, because the nerve is only in the very end of the tubule that's closest to the pulp. Okay, so the pulp then is super innervated with all the nerve cells and fiber endings. So if we have exposed pulp, then we have a real problem, right? But remember, they can produce odontoblasts that produce dentin, right? So as we age, we're going to get that secondary dentin. All right. The nerve endings then extend just beyond the dentino-pulpal junction. Again, that pulp is just extending into the pulpal end of the tubules. Okay. Now, the mechanism of dentin exposure is usually multiple events over time. So first you get gingival recession, then you lose your cementum, and then all of a sudden the dentin is exposed. And that's where we get our dentinal hypersensitivity. Now, let's talk a little bit about the hydrodynamic theory. Hydrodynamic theory is the theory that's most accepted now pertaining to dentinal hypersensitivity. And that is where they hypothesize that the fluid in the dentinal tubule just kind of causes pressure on the nerve endings that are extending on that opposite end, that pulpal end of the tubule. So it's that fluid in the tubules that's causing the sensitivity. All right, the relationship of dental tubules and nerve endings. Again, you can see, let me get my orange one here. So here's our CEJ, right? So we've had recession occur. Now we've taken out the cementum from over vigorous brushing, and now we have these open tubules. And what's happening is now this fluid is coming in here, and you can see these nerve endings on the odontoblastic processes that are extending into the dental tubule. And that fluid is just going to cause an incredible amount of pressure on those nerves, and that's what is causing the pain. All right, so here you can see recession in this area, recession right here, recession just right there. Here's our CEJ going to the gingival margin, CEJ going to the gingival margin. So we may anticipate that this patient has hypersensitivity. That's if the cementum is gone. They may have it even with a thin layer of cementum, okay? Remember, cementum isn't a great thermal protector, so anytime you have recession, it's quite possible that they have sensitivity until that secondary dentin or tertiary dentin is laid down. All right, then we have abfraction, and this is just kind of our physics lesson. And when you have pressure opposing each other, something's got to give. And what happens is during this occlusal, during extreme force, what happens is this part of the tooth here flexes, and then we get this cracking. I can't see where my pen is. Here we go. We're going to get this cracking of the enamel rods, and they're just going to kind of fall off. Okay, so you're going to see just a little bit of enamel and cementum, kind of a V shape. It's going to be more definitive. It's going to look like this if you're looking at it from the side. Okay, that's kind of bad, but what happens is that chipping happens, chipping of the enamel rods, and then that, along with some toothbrush abrasion, is now going to cause this really definitive abfraction. Okay? And here's our open dental tubules. I always like this picture. I think it's kind of cool that you can see these tubes and how you can just see how stimuli could get in there and things could be irritated. It's just interesting that those go right to the nerve. And this is just to relieve you guys a little bit. I thought I'd throw in some cute puppies because I think they are super adorable. We are so lucky because our bodies know exactly what to do with our hypersensitivity. Let's talk a little bit about sclerosis of dentin. The sclerosis of dentin is just where mineral deposits start to kind of build up in those tubules and block it off. Then we have our secondary dentin, and just like primary dentin, it is created by odontoblasts, and what the secondary dentin does is it's right towards that pulpal and dentinal junction, and it's just a walling off. It just the odontoblasts are stimulated, and they are in higher production there, and they're going to wall off and protect that pulp. Then we have our famous smear layer, which happens after we brush our teeth. Remember, it doesn't take too long for that to happen. And all that does is it just kind of occludes the dentinal tubules from having anything enter or penetrate into that tubule. Then we have calculus, and this isn't such a, the smear layer and the dental calculus aren't as ideal, I guess. None of it's ideal, but this provides a protective coating. So sometimes after we've done scaling and root planing, the patient will say, I didn't have any sensitivity until you did that scaling and root planing. Well, that's because we tore the Band-Aid off. Now we've exposed the wound. And so they may have a lot of sensitivity after scaling and root planing. And there are some products that we can apply to help with that, but it's not uncommon for a patient to say, hey, my teeth are more uncomfortable now. So what you need to do as a hygienist is make sure that they know that this could be a side effect of the treatment. All right, let's talk a little bit about the pain of dentinal hypersensitivity, the patient profile, because I always find this so astounding. Your book says that 12.3% of the population has hypersensitivity. So, in other words, you're going to see this every day, okay? And with an average of 3.5 sensitive teeth. That's crazy to me. Now, higher prevalence has been reported in periodontally involved patients, so we always have to keep that in mind. And where do you guys think this sensitivity is going to occur? So mostly it occurs on the facial surfaces of premolars and mandibular anterior teeth. Okay? Or it can be the premolars and molars, but generally it's the facial surfaces of the premolars and the mandibular anterior teeth. Again, think about where that wearing away, that toothbrush abrasion happens. And it's those canines and premolars, right? Usually a little more on the premolars. All right, then patient experience. So neural activity. So the effect of the fluid flow within the dental tubules can activate the terminal nerve endings. to or surrounding the dentinal tubules. Activation of these nerve fibers elicit a pain response. Now, pain perception. Remember, this is the stimuli going to the brain, and the degree of pain is not always proportional to the amount of recession, and that's really important for you to remember, because some people have a really high threshold, some people don't. Sometimes you see just a ton of recession all throughout, and there's no sensitivity, and then there's people like myself who have just a couple spots, and you pretty much have to peel me off the ceiling to clean my teeth. So definitely depends on the patient. Also, you'll find out in pain management that redheads do feel more pain and they are harder to get numb. It is a proven fact, so yay redheads. All right. And then the impact of pain, the hypersensitivity can manifest as acute or chronic pain. Stress may exacerbate the pain response. Remember that threshold might be a little bit lower, so it could elicit more of a response from the patient if it's lower. Okay. All right, let's keep moving on. Differential diagnosis. How do we tell if it's hypersensitivity versus an abscess? Well, we're going to do this an assessment and differentiation by collecting data via interview and diagnostic techniques and tests. So moderate to mild pain could be triggered by cold or sugars, resolves after the stimulus is removed. A lot of that you can ask your patient, right? That would be reversible pulpitis. Moderate pain, mild to moderate pain, spontaneous, localized gingival swelling, could be a periodontal abscess, or it could be periodontal cornitis. Okay? Or excuse me, pericornitis. Then we have severe pain. Now, is there swelling? Yes. Then we have an acute apical abscess. If there's not swelling, you may have pain to biting pressure. Okay? This could be irreversible pulpitis, or it could be an acute periapical periodontitis. So then you would do further testing there. All right? But we're going to look more at this triggered by cold or sugar, resolves after stimulus removed. That's our reversible pulpitis. This is generally our hypersensitivity. You can also use nice scales here when you're doing your interview assessment component. So a pain scale. How much does it hurt? Okay. Then we have educational considerations. We need to provide the patient with all of the information of what may be causing the sensitivity. And once you do that, then the patient should be able to discuss better home care in order to prevent further hypersensitivity. So maybe it's due to brushing too hard. Okay, they've worn away. There's now dentins, there's some erosion from acid or abrasion, abfraction, whatever it is that's causing those tubules to be exposed now, that dentin to be exposed. What can they do at home? Do they need a night guard? Do they need to change their diet? Do they need to brush lighter or buy a different type of toothbrush? So all those different educational considerations must be discussed with the patient. Now, the hierarchy of treatment, if somebody has severe pain, you want to take care of that immediately. But if they're looking for pain relief, we want to address the mild to moderate pain with more of a conservative approach. We aren't going to do a root canal, right, if it's hypersensitivity, okay? More severe pain may require a root canal or more aggressive approach. So you always need to look at sequencing of treatment. Start with the most conservative, and then, if that doesn't work, move to the next and then to the next. So you just don't want to start with a root canal right off the bat when it could be simply fixed another way, because With a root canal comes all sorts of other issues that could impact the patient's oral health. Okay? Then, as far as reassessment, you want to evaluate the treatment intervention, allow sufficient time to elapse, so 2 to 4 weeks before you ask the patient, how is this working for you? And also just make sure that you reinforce, hey, did you buy that electric toothbrush? How's that working for you? Are you brushing lighter? Are you using more of a sequence when you're brushing so you aren't over brushing that area? Anything like that. And then if pain persists, we want to then look at what else can we do for the patient. Oral hygiene care and treatment interventions, mechanisms of desensitization. I want you to know that the prevention of depolarization that interrupts the neural transmission to the pulp is one method, and the other is preventing the stimulus from moving the fluid in the tubules. Behavior changes, we want to make sure that our patient is avoiding the over-aggressive brushing. Maybe they need to stop sucking on lemons, whatever's causing the sensitivity, whatever that etiology is. And then if we made any product recommendations or we did any treatment, we want to make sure we follow up with them 2 to 4 weeks later, just to see how it's going. All right. Excuse me. Also remember using the perioade, they could burnish in the desensitizing agent into specific areas. If it's not generalized, they can just do it into that one area. As far as desensitizing agents, there's lots of different ways that desensitization can work. So we have many different products. We have potassium salts. Excuse me. These are often found in fluoride and toothpaste with fluoride, potassium nitrate. And that's probably our biggest #1 over-the-counter, available to everybody easily, desensitizing agent. And what those do is they just depolarize or reduce the depolarization of the nerve cell membrane and the transmission of the nerve impulse. So then we have fluorides, and fluorides basically just decrease the tubule lumen diameter, so it doesn't allow as much to come in. So it's kind of building that matrix, making it a little thicker. It also creates a barrier, okay, to the tubules. Then we have oxalates, and those just end up blocking the open dental tubules. The glutaraldehyde, I don't see this used real often, but it does exist, and it is a desensitizing agent, and it just creates calcium crystals inside the tubules. And what that does is it eliminates how much can come in to the tubule, okay? So it's just, again, just like the fluoride, reducing that lumen size, lumen meaning the opening, okay? Then we have calcium phosphate technology, and there are so many different products in this, but I just want you to pay special attention to the ACP, which is basically plugging the tubules. And then also I want you to pay attention to the casein phosphopeptide and amorphous calcium phosphate. And those work really well with acidic challenges. And so if you're looking at somebody who has a lot of erosion or they're having a hard time controlling their dental caries and they have hypersensitivity, that's the product for you. Then we have tricalcium phosphate. There's a great product made by 3M that helps with that, or that uses tricalcium phosphate. Again, just building that matrix, making it nice and strong, occluding the tubules, okay? The final one I'm going to talk about is the arginine and calcium carbonate technology, and this stuff is kind of newer to the market, meaning probably the last 5 to 7 years, and Colgate makes a great product that you just polish on for a few seconds, let it sit, repolish again for 3 seconds, just kind of occluding those tubules. And I mean, my husband has had sensitivity forever, and he had his first comfortable cleaning recently, and it was because they used this arginine technology. Self-applied measures, so patients can use fluoridated or toothpaste that have the desensitizing agents in them. Also gels where they can just kind of soak, you make a mouth guard for them, put a little gel in there and let them soak their teeth in it. Mouth rinses, generally not as effective, and it will cause some staining sometimes, so generally people don't want to use the mouth rinses. Now, professionally applied measures, we have tray delivery fluorides, we have fluoride varnish, we do have a varnish of 5% glutaraldehyde, oxalates, unfilled or partially filled resins just to block it, so sometimes a little restoration will be placed over that area. We have dentin bonding systems and glass ionomers. You're going to talk about that a little bit more in dental materials, but there is also the option of a soft tissue graft where there's recession present. If there isn't too much tooth structure gone, they could do a graft. All right, also additional considerations, periodontal debridement, using, excuse me, I gotta get a sip of water. Okay, additional considerations. Know that before you do any procedures that may cause sensitivity that the patient knows, they're more likely to accept it and not call the office complaining. And then give them post-procedure recommendations, like what can they apply at home? What can we apply in the office to keep them from having additional sensitivity? Another thing is that I want to mention is tooth whitening can sometimes and oftentimes induce sensitivity. So there are some products out there that have gotten a lot better with hypersensitivity. And generally it does dissipate over time, the whitening sensitivity. But if they do have exposed dentin and want to do whitening, you may want to apply something or give them a recommendation prior to the whitening. Okay? Documentation, you always want to document which teeth have the hypersensitivity, how you came to that diagnosis or the differential diagnosis, and all treatments that have been exhausted, have been used in the past, what they're doing at home, what you're doing professionally, and any instructions that you've given the patient to prevent further hypersensitivity in other areas. And then the outcomes and post-treatment directions, you always have to put the outcomes and post-treatment directions, what you told the patient, especially if you're doing scaling and root planing. You want to note that you informed the patient that there may be sensitivity after treatment, and then what recommendations you made for them or what you did for them in the office to prevent any further hypersensitivity. So, all right, if you have any questions for me, please let me know. Sorry this got so long. Take care. Oh, I'm sorry. I thought that was my last slide. Factors to teach the patient. Of course, that's always our last slide. And that is the etiology and prevention of gingival recession, the contributing factors for dentin hypersensitivity, mechanisms of dental tubule exposure, the natural desensitization mechanisms that may lessen the sensitivity, home care techniques, connection between an acidic diet and dentinal sensitivity, no toothbrushing after consumption of acidic foods because that's going to wear away more tooth surface and cause more sensitivity. So they need to neutralize their mouth for a good half hour prior to brushing their teeth. And then the challenges of managing hypersensitivity. All right, thank you.